We will continue to discuss unconscious bias in healthcare by looking at 2 additional readings. This video is part 2 in the series, and it's going to work the same way, where every now and then it will pause and a question will pop up. You have to respond to the question before you can move on. You can stop, pause, or go back at any time. All right, so this article is by Dr. John Freeman, and it is called How to Fight STEM's Unconscious Bias Against LGBTQ People. You can find the full citation at the bottom of this slide. This article is less about direct patient care in the healthcare setting, but it does still provide solid information about unconscious biases towards this group that do lead to worse health outcomes. This article focuses on the stereotypical assumptions or unconscious biases about people who are in the LGBTQ+ community. Dr. Freeman reports that these biases limit their opportunities for admissions to graduate programs, employment, and promotion. As we read a little bit further, the author points out that in STEM fields, LGBTQ+ people are roughly 20% less represented than would be expected. LGBTQ+ people also report more negative workplace experiences, with 70% of out STEM faculty reporting that they feel uncomfortable in their department. We also know that sexual minority undergraduate students are more likely than their heterosexual peers to leave STEM majors. After outlining these facts, the article discusses the Science and Engineering Equal Opportunities Act, which was signed in 1980. This charged the National Science Foundation, or NSF, with ensuring the participation of underrepresented groups in U.S. STEM fields and helping protect against the biases that hinder it. The NSF does collect nationwide data using several surveys that serve as sort of a STEM census. It includes a variety of measures such as gender, race, ethnicity, disability, income, and education. However, it does not collect information on sexual orientation nor gender identity. Some might argue that these measures would be too personal or sensitive to include. However, many government surveys in the US population already include this data, some even since the 1980s. On these surveys, there's always the option of I don't know or I don't wish to respond for individuals who would rather not answer the prompts. The author argues that by not asking these questions, the STEM institutions and healthcare organizations lack data to hold themselves accountable for tracking biases against LGBTQ+ people in STEM. This leads us to an overall discussion. So what did we learn from this article? We know that tracking sexual identity and gender identity is not only feasible, but essential to eliminate career and educational barriers for this group. Policy experts agree that LGBTQ+ people must be counted to inform policy and prevent discrimination in employment, housing, and other essential areas, like access to quality healthcare. The inclusion of LGBTQ+ people can lead scientists and healthcare providers to question their own biases and assumptions. The author also found that official signs of acceptance and inclusion do matter. The next reading we will look at is called Addressing Weight Bias in Medicine by Dr. Fatima Cody Stanford. The full citation can be found at the bottom of this slide. Dr. Stanford begins by stating that 2/3 of Americans are overweight or obese, and that for this population, the doctor's office or any medical facility is likely one of the least inviting places to be. There are usually no accessible chairs in the waiting room. Patients usually find that medical staff can't find the right size cuff to take their blood pressure. They might also be weighed in a disrespectful manner, such as in the middle of a busy hallway or somewhere without privacy. Often people share the concern that healthcare providers just give the repeated advice to just lose weight for their problems to be solved. This leads us to think about unconscious bias. Weight bias is pervasive in medicine. The prevalence of weight bias in medicine might stem, at least in part, from minimal education about obesity in undergraduate and graduate education. There's even less education about weight bias and stigma and its impact on the health of individuals who struggle with obesity. As a medical SLP, you will surely work with both pediatric and adult people who live with obesity, Yet, this is something that really we don't discuss much in the classroom. Obesity is a complex disease. It can't be minimized to calories in and calories out. Factors that can contribute to weight might include biological issues, such as genetics and hormonal changes that come with aging, developmental issues, such as parental obesity, psychological issues, including depression or history of trauma, or environmental factors, such as large portion sizes. These are just a few of the possible contributors. The article then talks about health consequences of weight biases. This includes changes in eating and physical activity, such as unhealthy eating behaviors, binge eating disorder, and lower motivation for exercise. Physiological reactions, including increased blood pressure, blood sugar, and levels of the stress hormone cortisol. Reduced engagement with healthcare services, including less trust of healthcare providers and poor adherence to treatment. Effects on psychological health and distress, including depression, anxiety, substance abuse, and suicidal tendency. Long-term health effects, including more advanced and poorly controlled chronic disease and low health-related quality of life. So how can healthcare providers undo weight bias and stigma? We can do this in a variety of ways. For starter, using people-first language in both written documentation and verbal conversations. A person has the disease of obesity. Avoiding words like morbid and replacing them with language such as severe can also be useful. That's the way that we would describe any other disease. I know you're already familiar with the implicit association tests. If you haven't already, you can take an IAT for weight. Often persons who have obesity have a similar amount of weight bias as those who do not have obesity. Providers and people can also take time to learn about obesity as a disease. Individuals can also speak about bias they see or experience in the medical setting. This can lead to more direct and explicit actions that reduce feelings of exclusion that individuals in this group experience. As a medical SLP, this could be something like noting that your facility doesn't carry extra long speaking valves, which might be beneficial to a person with obesity who has a trach, or drawing attention to the waiting room chairs in your outpatient clinic. The more that we call out biases against any population or group, the more changes that we will begin to see.